So without further ado, we'll move on to our next talk. I'd like to invite my teacher and mentor, Dr. Matthew Kurian. His topic is Target 65, How Have I Optimized My Surgical Outcomes? It's a great honor to have my mentor speaking in my IC. Thank you. Over to you.
Thank you, Rushad. So I'll be talking about how to optimize. And the need to optimize underlies the fact that not all formulae, even in the best of formulae that we have today, works as well. I have no financial interest in any of the talks. So measurement plus formula is what gives the IOL power, and it started in the late 60s. And prior to that, it was just shooting in the dark, and then you tried to come towards target bullseye. So the first step in improving the outcome was in improving the preoperative measurements. So contact biometry gave way to immersion biometry, then to optical biometers, and we have kind of reached maximum in the measurement, the limit which is called as a measurement flow, which is the limit to accuracy when measuring living tissue. Then we have to look at various formulae that are there. We started from the historic refraction kind of formulae to regression vergence, AI formulae, ray tracing formulae. And there again, we are slowly approaching what we currently believe may be the calculation ceiling, which is the limit to accuracy in the face of technological limitations. The formulae that we were familiar with for several years in the past were assuming that the axial length varied and the anterior segment size remained sort of normal. And so you had hyperopics, normal eyes, and myopic eyes with a normal anterior segment size. But then Hollady was a person to propose that, actually it is not 3 subgroups of patients, but actually 9 subgroups of patients. And the behavior is different. And when we look at optimizing, we need to look at this biometric data and then optimize each of these columns separately. Uh, the other big improvement that happened was the Haigis ULIB website, which gives optimized lens constants for multiple IOL models, and this is a continuously growing uh, field that is dynamic. The last thing is to obviously have uncomplicated surgery, because when surgery leads to complications, then everything is out of the window. Finally, the postoperative refraction measurement that is done, and this is where the manual error comes in, and I'll discuss that towards the end of the talk. So the sort of limitation that we have today is the ability to predict the effective lens position correctly. And now with the Haigis formulae, which has got 3 uh, variables, the Barrett Universal 2, which is a 5 variable formula, and the Hollady 2, which is 7 variable formula, we are able to look better at this 9 segments of the Hollady schema. And so we have the earlier versions formulas, which were using assuming a normal anterior segment anatomy, and the newer Olsen versions formulae and AI formulae, which is suitable for all anterior segment types. Dr. Hollady was also the first person to predict where the effective lens position would be, and this is by a multiple stepwise regression analysis method. Why this is important is because when the effective lens position that is predicted in the formula is equal to the achieved lens position, you hopefully get emetropia. A myopic error occurs when the effective lens position is anterior to the achieved lens position. The achieved lens position is anterior to the predicted effective lens position, and then rays will focus in front and you get a myopic error. You need to use a lower IOL power in those situations. The opposite is true. When the IOL is deeper in the eye, you need to increase the IOL power, because rays focus behind the retina. So we have this quarterly audit that goes on in our hospital to measure the variability in pseudophakic lens position and its impact on the outcomes. And this is the first one we did, which was as a clinical audit. The inclusion criteria was only for the central group on the Holiday formula, which is normal eyes, axial length 22 to 26 millimeters, white to white 10.75 to 13 millimeters, keratometry 41 to 47. Exclusion criteria was, of course, all the comorbid conditions and one-eyed patients. So, technically perfect surgeries were included with inner bag single piece aspheric foldable lens implantation. Routine post-operative examination. What was extra was at the 5th week biometry, there was a OCT done to measure the effective lens position. So the assessments that were done was the expected spherical equivalent calculation by the Barrett Universal 2 formula, and the TOMI OA biometer was used for the preoperative biometry as well as for the post-operative OCT. Achieved spherical equivalent was done in a 6-meter lane with the standardized versions. Achieved ALP, the achieved lens position was done on the OCTA scan, which is the OA2 2000. So refraction, when it is done properly, gives an error of 1/8 of a diopter, and swept source biometry is extremely accurate and is probably clinically insignificant. This is data from about 51 eyes and inferential statistics with intention to treat analysis was performed. The mean age of the patients was about 70 years, 41% were right. Mean IOL power was about 22 diopters, and the postoperative uncorrected distance visual acuity improved from 0.6 to 0.12, which is statistically significant improvement. The corrected distance acuity was 0.4, improving to 0.03. Again, statistically significant. The changes in axial length K1, K2, mean K was insignificant in pre and post-op patients, and cylinder and anterior chamber depth, because of the thinner intraocular lens, obviously, were statistically significant changes. We were able to achieve nearly 95% eyes within 0.5. NHS benchmark is about 55% in the less than 0.5 diopter range. And there was a significant correlation achieved between the spherical equivalent and the effective lens position. There was a inverse correlation between achieved spherical equation and the achieved lens position. So what we find is that there is a poor agreement between the refractive error at 1 month with the expected refractive error. When it is plano, that bunch in the center is okay, but as you come to the myopic side, what is achieved is less, and what in the on the hyperopic side, what is achieved is more hyperopic than what is the expected, and even in normal eyes. And there is poor agreement between the effective and achieved lens position, but there was no significant or systematic or proportional biases. So this is again just another representation of that same data. So we looked at subgroup analysis in terms of the IOL models that we used. So we were using at that time 5 models of lenses, 2 imported single piece foldable lens, multi-piece lens, and 2 Indian foldable lenses. When we look at the effective lens position calculation, we find that one of the lenses shows a large variance, which means that this lens is probably more sensitive to the geometry of the eye and is able to adapt to the geometry of the eye with different effective lens positions. Another one, irrespective of the geometry of the eye, tended to have one very particular fixed area for the effective lens position. And when we look at the achieved spherical equivalent, we find that the lens with the highest uh, variability or adaptability towards the geometry of the eye was the one with the best refractive correction. Plano spread is only 0.25 or less, whereas the one which is the most fixed in terms of geometry was having the greatest variation in the spherical equivalent refraction. So We know that two eyes with the same axial length and keratometry may require different IOL powers for emmetropia due to differences in the actual measured distance of the lens from the cornea and the individual geometry of the lens model. The IOL power prediction curve for most formulae give the same predicted IOL power for a pair of axial length and corneal power measurements and a given lens constants. Basically, when we are optimizing or personalizing the lens constant, you're just moving the whole plane up or down. So the implications for practice when we do this kind of analysis is to look at the interquartile range when you do the box plot. When you have a very narrow interquartile range uh, like that, okay, you can certainly choose to use this IOL because it's good. When you want to optimize, you just need to move that whole thing down. When you have a very large interquartile range, you need to check the IOL geometry, because even if you move the whole median down, you still are going to have a fairly large spread, and that is going to be the limit of the results that you can achieve. Sources of IOL power calculation errors today are ELP prediction and postoperative refraction. And as we improve the ELP prediction, we will be able to get better outcomes in this. So the future models is going to use more and more AI, larger databases, and we'll hopefully be able to reduce this error as time goes by. Thank you very much.
Thank you, sir, for wonderful talk. Just wanted to bring out one more point regarding Rex's size in an ELP. Do you think would that also make a difference? Not for an experienced surgeon like you necessarily, but for someone who is starting out, would that make a difference?
Okay, so when we are talking about all this kind of optimization, precondition is the assumption that we are going to do a technical perfect surgery, which means centered rexes, adequate overlap 360 degrees. That is the precondition. If you are not able to achieve a technically perfect surgery, then all these things go out of the window.
Yeah, because a larger axis tends to move the lens anteriorly, a smaller one posteriorly. So that is something to watch out for. Yes, Dr. Rish.
So, sir, all these online calculators have different refractive indices that they allow you to use of 1.3375, 1.3315. So, we by default use 1.3375 because our biometers are standardized for those. So, in some of the other countries, they use 1.3315. In that case, if we are using the EKR or would it be correct to use it using the same, or would you want to change the refractive index of the?
So I have the largest amount of experience using the 7.5 uh, refractive index, and I would stick with that. Okay. See, it doesn't matter what numbers you're using. If you're using the error, if you're using the wrong number there, uh, in your calculation, you will get a fixed error. As you move the optimization curve up or down, you will be able to neutralize that change.
Okay. Thank you, sir.
So, any more questions? Yeah.
Um, the lenses with the lowest interquartile range would probably be better for prediction of alphas, right?
Yes.
So could you tell us which those lenses were?
Yeah, so our two lenses in the imported category were the Alcon IQ single piece and the Technis monofocal. The Technis monofocal was the one which gave the least prediction error.
Okay.
The Alcon monofocal tended to give a little bit on the hyperopic side, on the myopic side, little bit more on the myopic side. So if you look at, say, let's say 100 IQ patients, you will find most of them are spot on. But if there is a surprise, the tendency would be to be on the myopic side. The monofocal was what we were using for our camp patients. It's Supraphobe, which is from Apasami. So that tends to give a fairly larger spread, and often there is a hyperopic surprise. So we would choose to go for the second myopic
Okay.
so that if worst case situation an error is there, the instead of having an unpleasant hyperopic surprise, you get plano in those patients, and the others you get monovision.
So even if you optimize your A constant, the
When you
spread
have
would
a
still stay
yeah,
the same. It would just shift.
it just shifts.
Shift.
Okay, so knowing the spread is
It's
critical before you start trying to optimize.
And you said it would depend upon IOL geometry. IOL geometry would change with IOL power as well. So, like,
Most for the standard IOL powers, the geometry does not alter too much.
okay,
Okay, like for example, the sensor range. Okay, it is equibiconvex, but then as it comes towards the highly myopic side, it becomes uh, meniscus lens.
okay,
Okay, so the geometry changes only in very large extremes. Otherwise, it
okay,
more or less remains the same. And see, here I am doing only the central normal eyes.
right.
You need to do this exercise for axial hyperopes,
Okay,
axial myopes, nanophthalmos, ophthalmos
right.
separately.
And what is your, what would you say about pseudophakic accommodation? Like, how much of pseudophakic accommodation does it occur at all? Does it not? Or
It's not so much of a.
okay.
Thank you.
Thank you. So I'd like to invite our next speaker, Dr. Ikita Lal, a good friend. She's going to be talking on radial keratotomy and post-transplant eyes, getting better biometry in the most challenging cases.
Course. I'll be talking about radial keratotomy and post-transplant eyes today. Now let's understand the basic principle how radial keratotomy works. We have radial paracentral incisions. They cause paracentral steepening and a central flattening. This flattening actually occurs in a very small central zone, and that's how RK is different from LASIK. We have a smaller central flatter zone, typically 3 millimeters or less. And this surgery significantly changes not just the anterior corneal curvature as well as the posterior corneal curvature too. We have surface irregularities. There are areas which are steep and areas which are flat, and this leads to irregular astigmatism. We have all of these factors which ultimately land up in higher order aberrations and poorer quality of vision. These patients also have hyperopic shift over the years, and these are all the challenges that we face. What really happens when we are planning an IOL power in these cases is that we have overestimation of the keratometry, because a lot of keratometers as well as topographers measure the values in 4 millimeter zone, and here we have a very small central zone. As a result, we'll end up overestimating the keratometry, and third generation formulas would lead to underestimation of the effective lens position, and we would land up in a hyperopic refractive error. There are various IOL power calculation formulae which have been used for post-RKIs. This is one of the papers published in Ophthalmology 2020. And what they found was when the refractive history of the patient is available, we have the Barrett-Truquet, which works well. And when the refractive history is unavailable, we have variations of Barrett-Truquet. Without the history also, we can calculate with the help of the ACRS calculator. And that works, that in this paper, it was found that that works as well as the standard Haigis formula. Here they found that the double K holiday based on the IOL master and the Potman Hill based on Pentacam were less reliable than any of these. So before I talk about a couple of cases and really try to understand which formula to use, just a word about the ASCRS calculator. We have to select the prior RK module here, and a few of the important points that we need to keep in mind, that the target refraction that we enter for these patients has to be slightly myopic and not emmetropic. This post-RK data that we have to fill should be the most hyperopic refractive error that the patient has, because this would account and correct for the hyperopic shift that these patients experience, and also the myopic shift that can happen due to nuclear sclerosis once these patients develop cataract. So ideally, this refraction needs to be before the patient has developed cataract. Then we need to fill in this value of the Pentacam. This is from the sagittal curvature map, the mean keratometry value at the 4 millimeter zone. So how do we decide what target myopia we should fill in the ACRS calculator? It could range anywhere from 0.5 to 1.5 diopters. And what are the factors that help us decide this? First is the number of incisions. If we have a 4 incision RK, we are probably okay just filling in 0.5 versus a 16 incision RK. How regular these incisions are, if they're associated astigmatic keratotomy, then we would probably aim for slight myopia towards 1.5 diopters. And also the present refraction of the patient would affect our decision. along with the distance from the center, how small the central zone is. Smaller the central zone, we need to aim for slight myopia. So let's look at a few cases. The first patient is a 69-year-old male who has undergone 4-incision RK surgery 25 years ago, and now he's planned for left eye cataract surgery. And we see here that actually the topography looks pretty regular. The thickness is not too altered. And when we do a look at the pre-cataract workup and compare the distribution of the power in the pentacam as well as look at the optical biometry, we see that the astigmatism is corresponding here. And we need to look at the axis of astigmatism more than the magnitude. If we have axis of astigmatism which corresponds within 10 degrees, probably this is a good case to plan a toric IOL for, especially if we have repeatability of these readings. Then we fed in all the data in the ACRS calculator, and here is the result. So we went ahead with 23.5 diopters of final IOL power. And if we had used Haggis, we would have also selected either 23.5 or 24 diopters. Now, a second case has undergone 8-incision RK about 30 years ago, and look at this topography now. It's much flatter than the earlier case. And what is interesting for this patient is that he's still myopic, even though he's undergone radial keratotomy. So here, when he's still a myopic, we need to look at the axial length when we are looking at the IOL power calculator. And this is the lens star printout as well as the IOL master. And we see that the axial length is 30.76. And that's how the IOL power that we are getting is more myopic. So we have to correlate all of these factors, the patient's present refraction, the axial length, as well as the IOL power that we are getting on these formula. So again, we use the SCRS calculator here, and the result shows us that anywhere between 13.98 to 16.43 in different formulas the patient should do well. We have kept an offset refraction. Target refraction has been aimed at -1 diopters here because he has undergone an 8-incision RK. So we finally decide to implant a 15.5 diopter IOL for him. We can look at the incisions here. They are pretty regular. Here we are more likely to have a preferable outcome than when the incisions are quite irregular or associated with astigmatic keratotomy. So here the points to take away from this case are that if the IOL power is less than 20 diopters, then we must cross-check the patient's refractive error. If he's in high myope, look at the axial length. And this is the post-op refraction of the patient 2 months down the line. Now, a third case here is a patient who has undergone a 32-incision RK. He's a scleral contact lens wearer, and his earlier refraction is still hyperopic with a significant amount of astigmatism. And we look at the keratometry here, we can see how flat and irregular this cornea is. So definitely this is not an ideal case for us to plan toric IOL. He's already a scleral contact lens wearer. And when we look at the optical biometry, we know that these readings are not accurate. When we look at the keratometry here, we are way off than what we are getting on the topography map. So here, using the values from the pentacam, which would be better for us and would give us a more accurate result as compared to the optical biometer. So this is what we do. This is the mean keratometry value. And when we feed it into the ASCRS calculator, look at the difference here. The IOL master, the lens star, is giving us a completely different reading from the pentacam reading. But if we had missed all of these findings, if we had not looked at the topography, we would have landed up in a absolutely very gross refractive error in this patient and a huge hyperopic surprise. So we implant a 29 diopters of IOL here, and this is a refraction at 1 month post-op. So to conclude about the post-RK cases, target refraction should be always aimed at slight myopia. Using the ASCRS calculator is very effective, but we have to also analyze the topography and probably look at the flattest keratometry value that we get. If the keratometry is more than 40 diopters, we have to keep in mind that this could be a paracentral reading and might not be accurate. Now, I'll talk briefly about the post-transplant cataract surgery. The first question is, when do we take up a patient who has undergone corneal transplant for cataract surgery? Preferably 1 year down the line when all the sutures are out, but it is not absolutely essential for us to plan these cases after all the sutures are out. Even after the sutures are in and we have done a topo-guided suture removal, we have to wait for 2 stable topographies, and if we feel the topography is stable, then we can still go ahead with cataract surgery. And a topography is a must before taking up these patients for cataract surgery. We have to look at the surface and see how regular it is. Evaluation of astigmatism would help us decide what kind of IOL we need to implant in these eyes, whether it is regular or irregular. So how do we choose the IOL? When we are looking at the astigmatism, when we look at the topography, if it is regular, we could think of using a toric IOL. If the patient is a RGP or a scleral lens wearer, then we have to absolutely avoid toric IOLs because it's very difficult to correct an astigmatism that has been corrected at the IOL plane later on. Toric IOLs are useful when the astigmatism is regular, when the topography is stable and it is repeatable. In a full thickness penetrating keratoplasty, I would avoid multifocal IOLs, but we can plan multifocal IOLs in patients who have undergone DSEC or DMEC. So I would just show you a small video of this patient who had an astigmatism of 5 diopters after corneal transplant. She has undergone a full thickness keratoplasty 3 years ago. So here we have planned a toric IOL, and we can even use customized toric IOLs for these patients, and they work really, really well if we have a high astigmatism. So I'll skip through the video in the interest of time. And I would just like to end with a few salient points. About IOL power calculation in post-transplant eyes is lack of data for us to clearly understand how to plan these cases. But what would help when we have a full thickness graft is to always target 1 to 2 diopters of myopia. Post-DSEC eyes, we can expect again a hyperopic shift, expect 1 to 1.5 diopters of hyperopia and adjust accordingly. Post-DMEC, we would probably not expect that much of a hyperopic surprise, and just targeting 0.5 diopters of myopia would be helpful. Thank you everybody for your patient listening. Thank you.
Thank you, Dr. Ikeda, for a wonderful talk. Any experience with the custom toric?
Sorry?
Any experience with the custom toric lens?
Yes, I have used it. We have the Ultra Smart Toric from the care group, and it works pretty well, and they can customize it for you for even up to 10 diopters of astigmatism. It does work well for these eyes.
I had done one in about 10 diopters, and it worked actually quite well.
Yeah.
Thank you.
Thank you so
much.
You.
Next speaker is Dr. RUSHAD SHROFF. I invite him to give his back-to-back talks on total EKR and other EKR variations which apply to different concepts in the IOL power calculation, as well as his IOL power calculation in keratoconic and ectatic eyes. Thank you.
So good morning, everyone. I'm just going to combine these two talks, and since some of the previous speakers have covered some of these concepts, I'll keep the first talk very brief. So we can skip over these particular slides. The reason why we need so many K readings is because of these eyes which are not following Gulstrand's law. So you have post-LASIK corneas which can have a wide range of curvature within the central 3 mm zone. You can have post-myopic eyes that can miss the central flatter zone and tend to overestimate the corneal power. You can have errors in ELP, as Dr. Matthew elucidated earlier. And keratometers and topographers measure only the anterior surface, and this changes after you've had a refractive surgery, as Tushar had mentioned earlier. So I'm just going to skip over the EKR because I think it was covered in detail. But as Ikeda mentioned, it's very important to look at the way the EKR is distributed. The axis is important because you have changing axes in the 4 mm zone, then you may have difficulty in putting a toric lens in these cases. The histogram at the bottom tells us about the distribution of the K readings, and a single peak or a higher peak is better. You can have up to 2 peaks in normal corneas. The other thing to look at is the standard deviation, which should be well within the normal range before going ahead with a toric or a premium IOL in these. Another thing to note is the pupillary diameter. When you're looking at EKR and selecting the IOL power, if the pupillary diameter is 3 or 4, go closer to those readings. If it's anything more than 4.5, stick to the 4.5 mm zone reading actually for the IOL power calculation. So this was also covered. EKR is important in keratoconus, post-refractive surgery eyes, PMD, irregular corneas, post-keratoplasty, and in eyes with a poor ocular surface. Now, the reason why I brought up true K and total K is that there is a confusion. Very senior people often also interchange these terms. true K is a formula that is used for post-refractive surgery eyes, and we have to be very, very clear on that. And total keratometry is actually something that we do when we are looking at the total, we are looking at the posterior corneal astigmatism as is measured by devices. So instead of predicted posterior corneal astigmatism, you're looking more at actually measuring it. So the TK that we refer to in the formula, the Barrett Universal 2 with the TK, is actually talking about the total K, not the true K formula. So total keratometry combines the anterior and posterior corneal surface measurement as well as corneal pachymetry. TK is designed to be equivalent to K readings and therefore can be used in standard IOL power formulas with existing constants in normal eyes, and it's designed to match the Gulf-Stranz ratio. So this is the Barrett toric calculator. You can see that the predicted PCA is measured and the measured PCA, you can select either of these two modes. Using total keratometry with the predicted PCA would tend to give you overcompensation of the posterior corneal astigmatism, and this is practically something that one should avoid while doing IOL power calculation for toric IOLs using this formula. So the newer Barrett formulas for the total keratometry include the Barrett TK Universal 2 for non-toric IOLs, Barrett True K with TK, which is basically for post-laser vision correction eyes, and the Barrett TK Toric for toric IOLs. So I'll move on to the IOL power calculation in keratoconic and ectatic eyes, which we'll go into a little bit more in detail. Why is IOL power calculation in keratoconus challenging? One, because it's an irregular astigmatism. There are errors in ELP estimation. There's non-alignment of the visual axis and the steepest portion of the cornea. There tends to be a hyperopic shift or an overestimation of IOL power on optical biometry. The cone location can influence outcomes, and the keratometry measurements tend to be non-repeatable. So Casey violates these rules because the refractive index of 1.3375 does not actually work in this. Like I mentioned, non-alignment of the visual axis and the steepest portion, and the larger deviation of the ELP. The optical biometer tends to overestimate the corneal power, and therefore you get an underestimation of the target IOL power and a postoperative hyperopia. So one important thing in history to take in your keratoconic patients are they contact lens wearers? This is important because they have to be off their contact lenses. You'll have a lot more rigid lenses in these patients, so they have to be off that for about 2 to 3 weeks. Otherwise, contact lens warpage can occur. It's important to aim for a slightly myopic target, and as was mentioned, if there are contact lens wearers with scleral lenses also, it's better to avoid a toric IOL. You may change the axis of the alignment of the cylinder in these patients, and they may not accept that very well. You have to explain to the patient that a toric IOL, and this is basically an astigmatic debulking procedure. It's not something that's going to get rid of the astigmatism completely, and avoid toric IOLs in patients who are happy with the scleral lenses or their RGPs. The important thing to remember is to under-promise and over-deliver, and you have to counsel them regarding possibility of IOL exchanges or piggyback IOLs. So when do you plan a cataract surgery for a keratoconus patient? There should be a visually significant cataract, and it's very important that the keratoconus should be stable. That's important to look at on the tomography. Look at Kmax values should not deviate more than 1 diopter over a 6-month period. There should also be a relatively stable refractive error and no history of progression at that point in time. So this is a review by a paper regarding keratoconus. I'll just like to highlight a few points. The first thing that I mentioned, the keratoconus should be stable. The other thing to look at is the severity of keratoconus, and I'm going to come to that in a bit more detail because of the use of the IOL formulas depends on the severity of your keratoconus or your ectasia. Toric lenses, like I mentioned, if they're planning to use their scleral lenses or RGPs post-surgery, then maybe better to avoid a toric. Coming to choosing the right IOL formula, there are various different papers on this. Most of the traditional IOL formulas don't tend to do so well. There's a paper published in JCRS talking about the Barrett True K formula, which does very well. The Barrett Universal with the TK also does quite well, and the Kane formula has also come into vogue for this, which actually does well. In the traditional formulas, SRKT tend to cause a little more myopic shift, and that was actually good for a keratoconus patient. So here are some examples. This is that of a 48-year-old lady with keratoconus. She had significant cataract in the left eye, which is basically of a posterior subcapsular nature. This was the tomography. The patient wanted a toric IOL. We counsel her saying that there would be some amount of residual cylinder because the IOL power we were getting was more than the highest that can be corrected with the imported lenses. And in this, when we look at the biometry sheet, what we got here was the SRKT was showing about plus 15 as the IOL power, and the Barrett TK universal was showing about plus 14. When we repeated the measurement, as was mentioned earlier, you can see that there's a little variation. It's coming to about 14 and 13. This was what we looked at regarding the EKR report. And because the axis was relatively well matched, we decided to go ahead with a toric in this particular patient. The pros for the toric IOL were that the auto K, the IOL master, and the pentacam axis was matching. The patient was not a contact lens user. The magnitude matched reasonably well between the three devices, and it showed consistent axis and magnitude in the central 4.5 mm zone. The cons for the toric IOL was that the IOL master 700 TK magnitude was higher than what was coming in the pentacam. The IOL power calculation, as is mentioned in keratoconus, it can be a little bit tricky. You may not be able to hit the target. And as I mentioned earlier, problems with the ELP, etc. But with all this in mind, we decided to go with a monofocal toric IOL. And we went, in this case, looking at both the SRKT and the Barrett TK universal formulas, and we went for the slightly more myopic value. This is a paper that talks about biometric prediction error, and this was a case where we had a mild to moderate keratoconus, and because the error was not very high, it's about minus 0.3 diopters, we decided to go ahead with the toric in this. And these are the various different, we fed in the auto K values, the pentacam sim K values, as well as the IOL master TK values, just to kind of confirm. What I'm trying to say is it's important to compare all these devices before you actually go ahead with the toric implantation. We also did the EKR, and we also used the Kane formula. And the Kane formula seemed to correlate very well with the Barrett Universal 2 formula in this particular case. What we found post-operatively was that there was about a residual refractive error of minus 1.25 cylinder and a plus 0.25 spherical error. The patient was reasonably happy with this, and this was a happy result at the end of this procedure. The next case I'd like to show is that of an advanced ectasia. This was a patient who was using scleral lenses in both eyes. This is the left eye with a Kmax of 76.8. So the calculation using the pentacam K values, it was found to be a high minus actually when we actually put this into the IOL master. Due to severe keratoconus, we used the standard Ks. As I mentioned, when you have higher keratometry to go with standard Ks, we used the 43.25 standard Ks. And these are the IOL powers that we got. We decided to go ahead with plus 13 in this particular case. In the other eye, we got a Kmax of about 62. So again, it comes under the severe keratoconus category, though not as severe as the left eye. When we looked at the IOL master calculation, it shows about minus 2 diopters as the target IOL power in this particular case. We also went ahead with the Kane formula, and this has actually been a revelation once I've started using this formula. We put the IOL master values with a target refraction of 0, and it showed a plus 0.5 lens. We used the target refraction of minus 2, and we got a plus 4. And with the pentacam with the pentacam values with the target refraction of minus 2, we got a plus 6.5. We decided to go ahead with the plus 4 in this particular case. And these are the post-operative refractions. In the right eye, we got pretty close to the emmetropic power with a 1.5 diopter cylinder. The patient was 20/20. In the left eye, due to some amount of corneal scarring and of course a little bit of residual refractive error, though more on the myopic side, we had a patient who had vision of 6/15 parts. The specular count was showed no significant change, and the patient was reasonably happy, and he was happy to use a scleral lens in the left eye. So the take-home points are: it's important to confirm the cylinder axis and magnitude on at least 2 devices. In keratoconic eyes, we always target myopic refraction. Pentacam EKR map is a useful tool while planning premium IOLs or toric IOLs in these patients. The Barrett TK True K, the Barrett TK Universal 2, Kane formula, and SRKT are good for keratoconic eyes. And always, the most important history to take is the comfort with the contact lens for these patients, because that actually determines whether you'll put a toric IOL or not. Thank you, and these are my acknowledgements.
We'll move with the next talk. Dr. Pooja will talk about how to handle extremely irregular eyes. Any questions? Yeah.
Till the puja setup, Rishabh, you have a pentacam AXL or a pentacam plain?
Plain pentacam, sir.
If it is AXL, then you can go for the 7E calculator for this.
I know. I
It
just
will-
saw that, but we don't have the AXL actually. Just now we have the pentacam HR. But the 7E, yeah, it would work well for this.
That is a very good tool for the particularly keratoconus. It gives better results than the Barrett one.
Yeah, so Kane has actually been giving pretty good results as well, and I've been quite happy. Even in a severe keratoconus, it got us very close to the actual IOL power of the patient. Thank you, sir.
Thank you, sir. I would like to thank Rushad for including me as a part of his IC. So I'm going to be talking about corneal customization before and after cataract surgery and how do we achieve the best outcomes. So cataract surgery after refractive surgery is going to come as a role in all of our practice. And so we do know that nowadays we do start getting patients who come up with, who've developed cataract and who had a history of refractive surgery in the past. Now, as these patients have had a refractive surgery in the past and they have been spectacle independent, their demand after cataract surgery also is that they want to be spectacle independent after cataract surgery also. Now, we do have a lot of options of good IOL power calculators, the best of IOLs, and of course, surgeon and the clinical experience. However, you cannot ignore the cases which you see here. The center one, what you see is a well-centered topography. But if you come across this kind of a patient who is post-LASIK surgery, you can see it's grossly decentered. And in the pupillary area only, you can see a scattorometry difference of more than around 5 to 6 diopters. So these are the patients who are probably going to be unhappy after cataract surgery as well. And if you have a regular cornea, the refractive error, the IOL biometry is not going to be a challenge, but otherwise, yes. And if the patients have a decentered topography or a decentered ablation, they're going to have a lot more higher aberrations on the cornea, higher HORMS, coma, spherical aberrations. And if you do a cataract surgery on these patients, they are going to be unhappy after surgery with the quantity of vision, quality of vision, and that's going to impact their quality of life also. So if it's a well-centered topography like what you see here, it's not a problem. But if you see something like this and you go ahead and do a cataract surgery, then the challenge comes. And the challenge doesn't only come in the post-surgery outcomes, but it also comes when you're dealing with for the IOL power calculation as well, because it can probably affect your accuracy of IOL power calculation, and also reduces. There will be refractive error surprise as well. So, of course, Matthew sir would be a better person to talk about this, because when we've all learned that how they worked on this technique called corneal customization before cataract surgery, which is known as C3, where they do cataract surgery and then proceed with the, where they first regularize the surface for this irregular corneas and then they proceed with the cataract surgery. Now, why they do it? Because if you do a cataract surgery before regularizing the surface, post-surgery there is going to be a refractive surprise, and there is going to be a poor quality of vision. And then after that, if you do a corneal regularization, then there you can have a refractive surprise. So it's always ideal that you do a surface regularization first and then do a cataract surgery, because whatever refractive error is induced because of the regularization, you can compensate for it with your IOL power or IOL biometry during the cataract surgery. So this is the nomogram what we follow. This is a published work where we have I made a simple nomogram of how you can proceed in your clinic. If you do straight away go with a cataract surgery, or if when do you do a corneal regularization first and then proceed with the cataract surgery. So let's look at these two case examples. This was a 58-year-old unhappy patient. She had a history of PRK 20 years back, and this was his refractive error. She did come with cataract, but what history she gave was that she has been seeing persistent starbursts since the time of her refractive surgery. So this is a case where she doesn't have a poor quality of vision because of her cataract or development of cataract, but her quality of vision has been poor since the time of refractive surgery. The history taking here is very important, that since when the quality of vision is bad, and when you do a detailed evaluation, you do come across this topography. And here what you see, this refractive error might not be completely because of the cataract, but it can be because of the decentered ablation. This is a classic example of decentered ablation, and this could have led to starburst after surgery. So now she has developed cataract, but if you proceed with a cataract surgery directly, she's still going to have starburst after surgery, even if she's emetrope. So you can choose any machine you want, but you need to do a topo-guided treatment in these patients. So you can do it either on Wavelight or your Schwint Amaris or any machine who has a combined topo-guided tool. So you do scans, export the good quality scans, and you set the Q value within the normal range. Then you set the refraction to 0 and check for C4, C12 compensation. Once you have compensated for the C4 and C12, you add the myopia with Q range being 0. And then you balance for the difference of myopic and hyperopic ablation for the refractive error correction, so to consider for the treatment, and choose the treatment with minimal ablation. So this is what probably you would do for regularization of surface, and this is also told here in chart that what stepwise you do: set the Q value to 0, Q will lead to induction of SA, set the refraction to 0 and check for C4, C12, compensate for C4, C12, add myopia. Once the C4, C12 are equal, then you can choose the treatment with minimal ablation. And this is what the decentered ablation looked like, and this was the EKR map. You can see that there is a peak, however, there is a huge flat zone present here as well, but after the regularization, you can see a peak here, and the toricity and the keratometries have come well within normal limit. Now the question here it's going to come is that if you have done a corneal regularization, but when to do a cataract surgery. So you do a clinical topographical assessment, you check for the stability of topography. Once the topography is stable, at least 2 time points where your topography has been stable for 4 weeks minimum between the 2 time points. Once you see that, you can go ahead and plan a cataract surgery, and you can use one of this. Of course, all the previous speakers have beautifully spoken about what calculators to use and how. So that is what you do here. And you can see this was the quality of vision of patient before the TCAT, before the regularization. This is after the regularization, and still there was a lenticular aberration present. So that is why her quality of vision was poor. But once you do the cataract surgery, this is what happens. Thank you. Yeah.
Thank you very much, Pooja, for a very nice talk. Any preferred technique of doing the corneal customization?
So it depends. Again, the history there comes into play, whether they have undergone a LASIK surgery or whether they have undergone a PRK. A lot of these patients who are coming here have either undergone RKs or PRKs. So there you will opt for a surface regularization. But if they have a history of LASIK surgery, if you have an OCT where you can see the flap margins, if the flap are even and they're not very irregular, you can always go for a flap lift as well. But history is very important. You have to have your OCTs into hand to decide, and then you proceed with it.
Yes, sir.
So many patients of RK surgeries which have been multiple RK incisions, and they have a iron deposition and a stellate lesions on the cornea, and so many, and any machines are not giving the keratometry readings. Then can you treat for the surface irregularity for those patients, and how you can
Yes.
consider the keratometric value for those patients?
If I have a minute, I can just show what we did.
Yeah.
I had a case, but I didn't show because
If you
of the
can.
time. Yeah, just I'll show the pre-op and post-op. We did have this challenge, and Reshma only helped us in this case. She's here. So this is what it. Can you?
I think just summarize it as
Yeah,
quickly
this is
as
just the
possible.
pre and
Yeah.
post-op outcome. So this is what it was. It was an extremely flat cornea. You can see the keratometry was 27, the flat, and it doesn't, the calculators don't take it up. So we did a surface regularization for this patient, and this was the post-TCAT outcome, and that's when we proceeded with the cataract surgery.
Thank
so
you
you
so
can
much.
opt for that.
I'd like to thank all our speakers and the audience for attending early on a Sunday. Thank you so much, and It was a good interactive session. Thank you.